Good morning, Prof. Anuj.
Good morning, Dr. Diane.
Hi, how are you?
I'm fine, thank you. How are you?
It's early morning in India, is it right?
Yes, it's 6:19.
Yeah, because today we have a tight schedule in the morning until evening.
No issues. It's okay.
So that's why we start in 8 p.m.
That's good.
How in India now?
Okay, but a lot of cases are on the rise again.
It's getting down or getting up?
It's getting up now because of
Oh,
these festivals which we had last week.
mm-hmm.
So people kept meeting, and we are having more cases now.
Oh, so everything is offline?
Yes, most of the things
Mm.
are offline.
And how about in your school? Also offline?
Yes, everything
Oh.
we are doing online, and we don't go
Mm.
to the school still.
Oh.
So it's a little tough, and it's getting worse now. The cases.
Mm.
How about in
And
Indonesia?
how about vaccine in India? Vaccine issue.
It's going to take time.
Hmm. And India make it by themselves?
Yes, that's what they're claiming, but
Mm-hmm.
RNA virus little tough. I feel.
Hmm.
And how about in Surabaya? How is it
Yeah,
there?
yeah, we have a vaccine, but maybe some people have the what is that confused to get the vaccine because some issues said if we get the vaccine, we have more easier to get the coronavirus infection.
Okay, so it's tough for all of us.
Yeah, yeah.
Or else I would have been in Surabaya and lecturing today.
Yeah. And Indonesian people is more than 270 billion. It's a
That's
lot of.
equal. That's equal to our two cities.
Yeah, yeah. I think not far away from the India. India is also a lot of people.
India is second highest population in the
Yeah.
world.
Yeah, yeah, yeah. So it is not easy to get the vaccine for all the people.
Yes, it's very tough to control and get vaccination for all.
Hmm. Yeah. We wait around 8 minutes again.
Okay, no issues.
Dahlan minta tolong temennya ya sama Radit biar kita bisa segera mulai.
Siap, Dok. Iya, baik, Dok.
Prof. Anuj,
Yeah.
may you try to share your presentation maybe, because this is a okay.
It's fine.
Yeah. We're looking. Untuk para PPDGS jangan lupa untuk chat absen ya, nama dan NIM-nya.
Dok. Baik, Dok.
Ya.
Dokter Dian.
Yap. Langsung ya.
Dian.
Nih.
Sampai jam piro iki kok Yan?
Jam 9.
Oh, jam 9 ganti itu gitu ya.
Iya, makanya itu. Anak-anak udah saya kasih tahu harus on time supaya kita bisa start jam 8 persis ini.
Iya, iki Jam 8 persis iki.
Oke, kita mulai ya.
Iya, dimulai aja.
Okay, good morning, Prof. Anuj. Before we starting, let me introduce our audience. There is the Dr. Ira. She is a Vice Dean in Faculty of Dental Medicine.
Good morning.
Good morning, Mr. Anuj.
And
Prof.
then Professor Kun Ismiatin. She is a Chairman of Postgraduate Endodontic.
Good morning, Dr. Anuj.
Good morning.
Good. It's good to see you.
Same here. I wish I could see you. Not able to see
Thank
you.
you.
Yeah, I can see you now. Good morning.
And then Dr. Nani. She is a staff of Conservative Dentistry Department.
Good morning.
Maybe she's just sitting.
Yeah.
And all our students. So it's time for starting. Please let your time.
Yeah. Good morning. Good morning to all of you. So today, Dr. Anuj, I'm going to be talking about management of separated endodontic instruments, tips and tricks of how to manage these separated endodontic instruments. First, we need to know what is the reason that we break these files, or why are they separating in the canal. There are various factors which lead to this. It could be operator related, it could be anatomy related, it could be because the instrument which we used was not up to the mark, or it could be because the technique which we are using. So in operator related, it is concerned with the doctor who is working on how skillful he is and how efficient or proficient he or she is while working with the instrument. Plus, they should know which instrument has to be used where. So that's again a very important point. Next thing is anatomy related. So I've seen most of the students, what they do is they following this social media or this Facebooks especially, they end up making those keyhole appearances, small access cavities, and they end up breaking the instrument. So we need to know how big the access has to be or how small the access has to be so that you get straight line access to the orifices so that there is no inadvertent stresses being acted upon on these files. Next thing with anatomy related is root canal anatomy. So if you're having multiple curves, you should know which file, what taper of file, hand file or rotary file, or a combination of both. What has to be used according to the anatomy, curvatures, or sudden bends. So that is very, very important from anatomy per se. Coming to instrument related, you need to know the material and design. Why do I say this is about material and design is depending on the case, you should understand whether it's a curved canal case or it's a calcified case. Depending on that, you will have to choose an instrument which is having high cyclic resistance or torsional fatigue resistance. Then there's one more thing which with instrument related is manufacturing processes and errors. Sometimes what happens is we have done all our glide path, we have judged the instrument for the right canal, but suddenly it snaps in the canal. That means it breaks in the canal. It could be because during the manufacturing process, it was not done well. So, not all the times it is our fault, but it is not the other way around as well. That every time you blame the file system and say that it's a manufacturing error. So, you need to understand that. The last point, according to me, is the point which we don't pay much attention to, but it needs to be paid attention to. Why I say this is because we all of us are shifting to motors which are locally made or which are substandard, and these motors display that this is the RPM, this is the torque, but they are not delivering that RPM, they're not delivering the torque. So the instrument which we're using has an ideal settings, and if it is not used according to the manufacturer's settings, there is every chance that you separate the instrument. Next one is instrumentation technique. So if someone has told you it has to be a push and pull motion or it has to be a pecking motion, and if you change that, there is every chance that the instrument stays for a longer time than told by the manufacturers and it gets stuck up there. Reuse and sterilization. In developing countries, yes, reuse is a very important point because we use the instrument after autoclaving multiple times, but we need to know that let the instrument separation be not the last time you've used it in the patient. You should know how tough the case is, how easy the case is, accordingly and judiciously use your files in number of cases. The social media driven aeronautics is one thing which I would say don't go by it, because you would see a lot of images like this being put up on Facebook or any other social media and you would get amazed by it. But that's not how you need to work towards this. So we know the problem is could be related to us, could be related to the anatomy, could be related to the file system or how we are using it. So what is the solution to these separations and how do we get success to it? This is what we are going to be discussing in today's lecture. First and foremost, just don't go by anyone's one case. Like if I have reported a case to you that yes, yesterday I had an instrument retrieval case, I could do it. You should always read textbooks, read journals to come to a conclusion how, when, and where it can be removed. For that, you need an array of instruments and gadgets. Not every case will work with one gadget. So there are a lot of queries which are asked to me, which is the best instrument retrieval kit? So my answer to that is whichever works for that case. And the next question is again raised by the participants, which all systems to buy? I would say start off with ultrasonics and a magnifying device, and then slowly keep on building onto it. So before anything we start in separation of instrument, we should know how to identify it. So there's this beautiful article by Rosen et al., which talks about radiographic identification of separated instruments retained in apical third of root canal filled teeth. Here they have spoken about radiography. And to my shock or to your shock, you would get this as a conclusion. It may be difficult to radiographically detect retained instruments. It is easier to radiographically detect stainless steel than night eye instruments. Now, how many of us use stainless steel instruments? Most of us have shifted even for our glide path to our night eye instruments. So this is one article published in 2014 by Rosen, and the same author speaks about this during CBCT. What she says again here is here they have compared CBCT with your radiograph, and to your shock, the conclusion which they've given here is CBCT imaging is inferior to periapical radiography in detection of retained separated instruments located at the apical thirds, regardless of instrument type or sealer type. So here this article says that your RVG or your periapical radiograph is a better option in selecting or identifying an instrument. Let me go to two previous slides and show you that there's a case here which is referred to us because of pain, and this is the radiograph which was sent to us. We hunted and searched and we got the file out. But if I had not told you that the file is located here, see this is the fragment here, this one. So if I had not seen it under dental operating microscope, had I not hunted for removing the GP under the dental operating microscope, I'm sure I wouldn't have been able to find it. So there's a lot of confusion in identification of instrument, and this needs clarity. So my goal or my take home message for this part of presentation would be always make sure that you remove all the GP, remove all the metallic coronal restoration, then send for CBCT if required. And your faculty does have CBCT, and a good one, because I've seen it the last time. It's got good resolution and it can actually detect really well. So again, I would repeat, remove all the gut aperture which is there in the canal, or as much as possible, followed by removal of all metallic restorations in the coronal thirds, or if there is an amalgam restoration or if there is a crown, remove that and then send it for CBCT. So even if I leave this instrument in the canal, let's not talk about straight away in removal. Let's think if I leave it in the canal. So what is going to be the outcome of leaving it there? So there's this analysis or a big study which was done in 2005 by Spilly. They say that the rate is going to be as low as 67% and as high as 93%. But if you read this journal article really well, this is based, it's a retrospective study where they have selected cases from 1955 to 1965, and they at that time you do not have nickel titanium instruments. You had carbon steel instruments or stainless steel hand instruments. So you need to understand when you're reading an article, how is it correlated to us now? So this is a wonderful article, but then it does not have any significance to what we are doing today, because we are hardly using stainless steel or carbon steel instruments. Stainless steel instruments rarely your 10 number file or just for apical enlargement. So in this systematic review and meta-analysis by Piani, what what's the conclusion which they gave was the fracture instruments is, if it is left within the root canal, the prognosis is not significantly reduced. But one thing which you need to understand is, if it has a periapical lesion, then it affects the outcome. Now there is a catch in this study, is that this was done in a specialist practice and a well controlled university clinic, not like haphazardly by any private practitioner. So the conditions which were maintained there was, they would have done good isolation, they would have had good autoclaving of instruments, unlike the actual reality. So how do we go about managing these instruments, and how is it important? So this article published in JOE in 2013 by Madrati et al. Is a very, very good article for us to understand how to go about management of intracanal instruments. So they have given a flow chart which I do not per se agree with it, but let's get to the conclusion of what this article says. Here it says is, guidelines for management of intracanal separated instruments have not been formulated. So decisions on management should be considering these. This is very important. Number one, constraint of the root canal accommodating the fragment. Stage of root canal preparation at which the instrument separated. So if it is a shaping instrument which is separated and in a tooth which had a periapical lesion, the prognosis is going to be really very bad. And then if the instrument which is separated here was a finishing instrument or the last instrument just before you were about to remove and obturate, the prognosis is much, much better. Third point is expertise of a clinician. This is one point which I always like to highlight in my presentation, that know your shortfalls, know your shortcomings. Don't think that you can manage everything by yourself. If you're not capable enough of doing that case, please refer it to the person who is capable enough of doing it, or who has enough armamentarium to manage it. Because most of the times what happens is we do not have enough armamentarium to manage it. Next one, as I mentioned, armamentarium available, potential complications of the treatment approach adopted. So these points, that is 3, 4, 5, go hand in hand according to me. So sometimes what I feel that, yes, I can do everything, but I do not have enough armamentarium for it. So in order to overcome these shortcomings, I try to do something or the other and end up causing more harm than doing any good. So this is the conclusion of third point, fourth point, and fifth point. Last but not the least is the strategic importance of the tooth involved and presence or absence of periapical pathosis. So if we have a tooth which is going to be the whole and soul abutment for a long bridge, we need to be very careful about what we are doing to this tooth and how much of remaining dentine thickness is there, leaving this instrument, what it will cause. And if you do not think of removing it and leaving it there, what is going to be the prognosis of this tooth. So the armamentarium or the techniques which are going to be used Starting from chemical means, mechanical means, you have soft-hit gutta percha, you have multisonic, ultrasonic cleaning, you have electrolysis, you have laser. In mechanical means, you have techniques using ultrasounds or ultrasonics. I feel that ultrasonics is one thing which is the game changer, because you are able to see what you are doing under the magnification. While bypass technique, yes, I would say first attempt should always be for a bypass, because if you have a little space around the file, there is every chance that you will be able to get it out with your bypass or by your ultrasonics. In holding techniques, we have a lot of techniques like Messerin technique, Felts and Coauthor technique, metric endos, IRS system, endo rescue. You have endo cowboy now. You have BTR pen, which is available. You have Zoomax endo extractor, which is not a tube technique, but it is a type of holding technique because it has a claw, which I'll be showing you in the subsequent slides. Then you have tube techniques, endo extractor, canceller extractor. You have your hypodermic surgical needles, where you just put your cyanoacrylate on the tip and just hold onto the head and try pulling it out. Then you have separated instrument retrievals, different systems. See, there is so many in the market that you do not know which one to go about. And even after showing you so many techniques which are here, there are so many which are missing, because every alternate day or every week we are having more systems coming into the market. So what are the parameters influencing the removal of fractured instrument? Tooth factors, localization of the fragment, fracture instrument factors, operator factors, technique chosen, and patient factors. Let's get to the tooth factors. How is the tooth placed? Now, what do I mean by how the tooth is placed? If it is a mandibular molar and the instrument is separated in mesiobuccal or in the mesiolingual canal, and if the tooth is placed, or if the crown is submerged distally and it is raised mesially. So when I'm placing my mirror, I will have to be very careful how I go about managing my mirror, because whenever I'm working in a under the microscope, I am always doing indirect vision. So I need to have enough space in and around it to work into the tooth. So tooth plays a major role, how it is tilted, how it is submerged or how it is supra-erupted, and how is its relation with the adjoining teeth. Localization of fragment. So if we are good enough in localizing it with a radiograph or with a CBCT, CBCT does help nowadays because the resolution has increased and the artifacts have reduced now. So if you can localize the fragment, whether it's above the curvature, below the curvature, things become more easy, and it is much easier for you to plan about which technique you're going to be using. The next one is fractured instrument factors. So why this point is important is you need to know whether it is a stainless steel instrument or it is a NITA instrument, or if it is a overused NITA instrument. Now, I would be highlighting these points later again, but here I would like to say is if you're using ultrasonics and if there is a stainless steel instrument in the canal, it takes up energy faster and it has every chance that it'll puff out. It'll get uh, into a powdery form. Whereas with your nickel titanium instruments, they take up more energy, but the problem with them is they are more brittle. So sometimes you feel that the instrument is coming out, but it would have broken down. It would have broken into two pieces. So that makes your life more tough. Next comes operator factors. In operator factors, I would again say how efficient, how proficient you are, that only you can decide. So if you're not efficient enough to do it, please refer. The next technique is the technique chosen. Now, which technique would you like to choose? And which condition, which technique? So I would be showing you all the prognosis of all the techniques and then what techniques I use. Next is patient factors. In this, there are three things which I like to talk about. One is economical factor, whether the patient can afford this. Second thing is whether the patient can keep their mouth open for so long, because it would take quite some time to create a staging platform, and then identify the instrument and then remove it. Last but not the least is how well the patient is going to take it on a longer run, knowing the prognosis is not going to be as good as your straightforward root canal treated teeth. So in tooth factors which you need to understand in anatomical aspect is, if there is an instrument broken, if this is a mesolingual canal, mesiobuccal canal and distal canal, if you see in the mesiolingual canal, it is going to be very tough for us to get it out, because there is total engagement of fluids of the file into the canal or onto the surfaces. So what's happened is got drilled inside, and if it has got high torque, I hope you know what is torque. Torque is nothing but force during rotation. So if it's got sucked in, or if it's got clogged in with a lot of torque, it's going to be very tough to remove. Whereas this instrument in the mesiobuccal canal, you have enough space around it, so you can use your ultrasonics, dig around it little, and then use the ultrasonics in anti-clockwise direction. Now, why do I say that you need to go into the anti-clockwise direction is because the instrument has got clogged inside if you're using a rotary instrument in your clockwise direction. So if you apply your ultrasonics in anti-clockwise direction, it is going to lead to unlocking or opening of the threads and screws so that it comes out like a nail. Whereas in the distal canal or in palatal canal, you need to understand that there is enough space mesially, if you're talking of the palatal canal, mesially and distally, and if you're talking of a mandibular canal, lingually and buccally. So these areas are very thin in middle thirds and apical thirds. So if you work with your ultrasonics in these regions, you're going to cause strip perforation. At that time, you would see that yes, good amount of you've removed the file, but when you're going about for your obturation or just prior to your obturation, during your biomechanical preparation, you would see some amount of bleeding happening, or you would see a reddish hue being present. The taper of the instrument or the taper of preparation which is being done. Again, this goes into the correlation to the last slide, how much of space is going to be around the file in the canal. And one more thing which it's going to make a difference is, what is the thickness of the instrument which is there inside. And if it is a night instrument, and if I'm going to apply a lot of energy to it, there is every chance that because of its brittle property, it is going to break into multiple pieces, and removing that is going to be very, very tough. So talking from theoretical aspect or from journal aspect, which I mentioned in the beginning of my presentation, that we should read enough books or journals and articles, come to a conclusion of what these techniques have done, how good they are, how bad they are. So let's see how good or bad these techniques are, and then later come to seeing the cases, how we have gone about doing this. So in ultrasonics, a lot of studies being published, so they have success rate of as high as 84.6% and as low as 33% when it is in the apical third. So in ultrasonics, what, as I mentioned to you before, what do they do is they use ultrasonic energy in and around the instrument, expose the instrument, and then apply this same instrument in the anti-clockwise direction to the tooth so that it comes popping out. Tube technique. There are a lot of tube techniques which are available in the market, but the flaw with this, or I would say the thing which hinders us from using this is, if there is a curved canal, these are too stiff, they cannot be used in curvature. First thing. Second thing which we need to know about these is, if the canal is not as broad as this instrument, or let's put it other way around, that every canal has to be widened enough for making sure that this instrument reaches the fractured instrument. So there are going to be a lot of dentine cutting, and of late, or now, we know that we have to remove as much as least dentine as possible, so that we can preserve as much as remaining dentine there. So this This has a success rate of as high as 91% and as low as 45%. Canal finder system. This was one good system which was more like a reverse H file, and it would move in coronal apical direction of 1 to 2 mm. If there was any space in and around the file, it would get engaged there and try to pull it out because it gets engaged to the file. But the disadvantage was it would get engaged even to the dentine. So there was every chance that we would separate this finder system itself. And this has high success rate as high as 68% and as low as 19%. Laser irradiation. This seemed to be a very good concept, that you would use lasers in the canal and you would actually melt the instrument and solder it solder it to the tip which you're using during this your laser application, and it would adhere to that instrument and you could pluck it out. Now, there are two to three things which I want you people to pay attention to here is all these studies have been done in ex vivo, not in vivo. First thing. Second thing is why I say ex vivo is yes, it was done in the patient and the tooth was extracted and checked, but we do not know the periodontal status, because when you're using NDAC lasers for melting the instrument, there is going to be a lot of heat generated. The whole purpose of doing a root canal treatment is making sure that your PDL stays vital or your PDL stays intact. And if your PDL doesn't stay intact, the whole point of doing a root canal or our branch of endodontics is of no use. And here you need to see that they have got success rate of 77.3%, as high as that. But buying a laser unit just for instrument retrieval or for doing other procedures, I think it's a tough task, or it's a very high buy, or the return of investment in this is, I would say, least. Next is electrochemical dissolution. There was this article, if I'm not wrong, uh, at present I'm showing you the reference from a textbook, but when I was doing my post graduation 11 years back, and this was during my second year of post graduation, that there was this article on electrochemical dissolution. It seemed very interesting to me, but what troubled me was, yes, you're going to form an electrode and you're going to form a cathode, that is your anode and cathode. But the thing was, what about the salts? What if the salts penetrate in the periapical area? And second thing was, what if there was something called as shock generation? If there is some amount of electrical current being flown, and if it was conducted apically, I'm sure I'm not going to find it easy for myself. It's going to be very uneasy and I would not accept it. So all this has been done in vitro experiments. It's not done in patient's mouth yet. The results are fair enough, but nothing great, because uh, whatever electrochemical series or electrochemical cell which we are forming is going to be it's going to be a little complex because of the metallurgy of instruments being used nowadays. All are differently coated, different metallurgy, different faces, like N face, and different way they are being polished. Multisonic ultra cleaning system. Again, this looked amazing, gave wonderful results as high as 83% and as low as 61.1%. Again, it's an ex vivo study, it's not an in vivo study. The thing which troubled me here again was something like your lasers. Yes, lasers has got wide range of treatment modalities which can be done by it. Even multisonic ultra cleaning can be used for your non-instrumentation technique for cleaning your canals. It can help you in removing the instrument, but again, the cost of this unit is way high for me to have it in my clinical practice. So whatever we discuss here, we have to make sure that if we go tomorrow to our dental clinics, or tomorrow, sooner or later, once this COVID comes down and if we start working on patient, we should be able to apply it. So the combination of hand file and canal finder worked well. And this gave, because what happened was initially canal finder was used wherever there was space where it could just sneak in and could bypass. But whereas when you use hand file and canal finder system, if you remember sometime back I told you, if there is some space around the file and use your hand files to create a bypass along the broken instrument, it's very easy to get the instrument out. So in that case, if this canal finder is used, which will hook onto the instrument and try pulling it out, things get easier and it becomes much more easier for you. So here they have got a success rate of as high as 68% and as low as 21% in bypassing, not in removal. In removal, the success rate is as low as 33%. So all these things have been done with your naked eyes. So when you're working with these systems, especially Messerin kit, yes, especially in Messerin kit, once you've exposed the instrument and you put the tube inside the canal, you cannot see what's happening. So I'm not a big fan of Messerin kit or an IRS system anymore. Ultrasonics, yes, because it gives me enough space to see around the instrument and my microscope is still alive. So what I'm trying to show here is, see this in vivo, they've got success rate of 55-37%. That's not what we want anymore. We would want to use ultrasonics and get success rate of as high as 90%. And all this was done without magnification. So if you see the success rate, it's not as high, which can be seen here. But with dental operating microscope, if you see the least success rate or the minimal success rate is 67.7, 53%. Okay, let's put it 53% where they've used hand files and ultrasonics. But it goes as high as 87 or 88% in a clinical study. See, it's gone to 95% in a clinical study, not in ex vivo studies. So dental operating microscope is very, very important when I'm doing my instrument retrieval. So getting into clinics and understanding how to remove this fragment which is there in the tooth. So to begin with, take a GG number 3 or 4, take your burr and chop it right in between, right at the center, so that you have a flat burr like this. So now how this is going to help me is that even if this breaks, this will break from the shank here. It's very easy for me to remove. But what is this going to help me is that it's going to take me to the tip of the broken instrument. And then I can use it. So let me put it in an easier way. If you're hitting a nail into the wall or into the wood and the nail's head is broken off, now you need to remove that nail. To remove that nail, what do? You reach to the same flush of the nail head, that is somewhere here, and then try exposing 1 or 2 around it, then pull it with your plier and get it out. Something like this is what we are going to be doing in instrument retrieval in the canal also. So this is going to help me to reach the tip of the instrument and get it in flush with the dentine. Then I would use ultrasonics around it and remove at least 1 or 2 of dentine around it and expose 1 to 2 of the instrument. Please remember that when I'm using ultrasonic tips in and around the instrument, I have to keep it as minimal as possible. And then what I would do is take my ultrasonics, apply it to the instrument in an anti-clockwise direction. See, it's already started moving and it came flying out. So this is in an extracted tooth which I have kept for demonstration for recording this video. So if you see here, the fragment has come out, but the fragment has fractured because I have applied too much of energy to the instrument. I am not supposed to apply so much energy to the instrument. I'm supposed to go in anti-clockwise direction so that it unwinds or it unscrews from the canal and comes out. That is important for us. So I want to make sure that we Understand these points before we start using these techniques. These are very, very important points for us to understand where how ultrasonics needs to be used upon. So nickel, titanium, and stainless steel instruments respond differently to ultrasonic vibrations. Stainless steel instruments or fragments absorb the ultrasonic energy bodily and will show the movement early. And if you apply it right onto the tip of the instrument, they will puff out. Okay. Next point. Nickel titanium instruments are brittle and often break into fragments, which I just showed you in the last video, when subjected to direct ultrasonic energy, particularly if the fragment is tightly locked. That means if there has been a torque to the instrument, please remember these points or take a screenshot of these points. These are very, very important points, that if you're trying to remove a nickel titanium instrument, which you're going to be doing most of the times, if you apply direct ultrasonic energy onto the instrument, yes, and if this instrument is torqued inside the canal, and while applying the energy, it will break because it's brittle. So you have to apply it all around it in anti-clockwise direction. Last 2 points where they talk about heat generated and cyclic fatigue created by high frequencies waves of ultrasonic tips transferring to the fragment could be contributing factor to the secondary fracture, again with NITI instruments. Secondary fractures of the fragment appeared to be reduced when ultrasonic tip was applied into the inner curvature of the canal, not onto the tooth, not onto the file, but onto the inner curvature. So this is the whole concept on which the Teriachi kit works on. That is why they have a 6 o'clock and a 12 o'clock ultrasonic tip, where it has got a spoon-like shaped. If it is the spoon is facing downwards, it's 12 o'clock. 6 o'clock, and if the spoon is facing upwards, it's 6 o'clock. So it's 12 o'clock and 6 o'clock. So this helps you to decide where this scoop or where this spoon can be used in the curvature, whether the curvature is towards the inner side or the outer side. So now I would like to discuss few of my cases, which I started doing this retrieval way back in 2011, and now I've been practicing, and I want to show you how I have evolved, what mistakes I have done. I would not want you to do those mistakes and make your life much more easier. So this was a case which was referred to our department from a pediatric department. So what would you plan to do in this case? Here I feel that if I have a forceps or a knee or a holding technique which will make me go inside the canal, because this looks to be in at the CEJ level, so it's not it would be maximum as deep as 10 mm or 11 mm. So if I have a Stieglitz forceps, and you have different types of Stieglitz forceps, different angulated beaks, different length beaks. So if I have that, I could remove it, and that's exactly what I did. But now moving to the more important fragment, that is your apical fragment. If you remember, we spoke about tube technique. Tube technique can be used in cases where the canal is straight and the canal is big. So in this case, the canal is big and canal is straight. So we went ahead and used Messerin kit, the whole kit. Luckily, we had the whole kit in the department in our dental school, and we could get it out. So what I did was I exposed the fragment, took my tube, put it inside, went ahead in rotation in my micromotor or a slow hand piece, and then I put in my sleeve needle, locked it there, and pulled it out. So there are two disadvantages of doing that. First thing, I could not see what I was doing. Second thing, I did not know how much of dentine I have removed around it, and when I was pulling it out, whether I have caused micro fractures or not. And as I have not obturated this case, I had to send it back to the pediatric department. So this is one, I would say in the beginning I used Masaran kit, I don't use it anymore. Now this is a case where there is a broken file in the palatal canal and it has gone it's a huge fragment. It's gone beyond the apex and it could be in the sinus. So, what are the things which I had to pay attention to? First thing, whether it has perforated the sinus. So, if I try teasing this out, I should not have sinus fluid flowing through the palatal canal. As we know, the apical opening of palatal canal is huge. Third thing which I needed to know was I needed to pay attention to was that if I apply ultrasonic tips on the tip of the instrument, I should not push it into the sinus, because if I push it into the sinus, I will have to call an oral surgeon for a Cadwell look operation and we'll have to get it out. So these were the shortcomings, or these were the points which I had to think of while removing this instrument. So what I did here was, as I mentioned to you in the beginning, I always prefer bypassing first to see if there is any amount of space around it. If there is some amount of space, either with my normal hand filing, I will be able to get it out, or with ultrasonics because I have space to work around. But here I wanted to bypass it for two reasons. One, to see whether I have ruptured the sinus or if there is going to be sinus fluid coming through it. Second thing, which to know how much of space is around it. So after I bypassed it, I saw it again under the microscope and I could see, yes, there is enough space around this file for me to use ultrasonics. And the best part here is it is a maxillary molar. So the tooth is going to have this fragment apically, and the gravity is going to help me. The gravity is going to help in my favor, that even if the instrument is slightly loose and if I irrigate well, the file is going to come coronally, it's going to come occlusally, which is towards the gravity. Same thing if it is in a mandibular molar, the instrument would pop out and go back in, pop out and go back in. That is where I would need something to hold on to it. I hope you are understanding what I'm trying to convey here. So after we could do that, we teased it out with ultrasonics. We went ahead and obturated. But if you see, I've kept the obturation 1 to 2 mm short of the apex. Reason being, I was expecting some amount of resorption happening there because we have worked a lot at the apex. We have enlarged the biological apex. Next case. If you see this RVG, and once this case is referred to you, what you need to pay attention to is anatomical factors. First and foremost, there was a pulp stone here. Second thing, there was no straight line axis created, which is very evident when I opened it up, seeing this pulp stone. I had to clear this up, make sure I remove all the dental caries and get a straight line axis. To your surprise or to my surprise, it was very easy for me to bypass in this case. It was very easy. It wasn't tough at all. And when I started seeing it and exploring it to remove this instrument, I realized that this instrument is broken in the danger area of the tooth. That is on the on the distal aspect of the mesial root. And if I try removing this, there is every chance that I will have a strip perforation. So I need to understand, or I need to pay attention that in this case, bypassing it would be enough. Giving multiple dressings of calcium hydroxide and making sure that it's become asymptomatic and obturating it would be enough, rather than removing this instrument. Because if I remove this instrument, yes, I am successfully removing the instrument, but the problem would be that I would cause strip perforation. I would have to use MTA or MTA using MAP system, and I would complicate the whole case. It's been more than 5 years. This tooth is doing well. Patient is happy. Knowing when not to remove it is more important than always running behind removing it. So that's very, very important for all of us. Next case. This case was referred to me from a rural area, and the terms and condition was just remove this instrument and send it back to us. I would go, the referring dentist would go ahead and do the obturation. So this created a lot of doubts in my mind. Why was this statement told to me? If you pay attention to the X-ray here or the RVG here, it's a radix case. It's an extra root. This instrument is broken down in an extra root. And we always know that radix root is always thin and always curved. Plus, if you see the thickness of the instrument, it looks to be very thick. It's not long, but it looks to be very thick. So as I mentioned to you previously, I always take my 10 number file, try bypassing it. So I used multiple files, but I was always having this twirl. The file at the tip was twirling down or it was curving. I was not able to bypass it. So what was the best way I could do in this was do split damp or always isolate one tooth front and one tooth at the back so that you have enough space to work, especially under the microscope with ultrasonic tips and your mirror. In this case, I coated the whole canal or I lubricated the whole canal with EDTA solution and started applying energy in and around the instrument. And then the instrument came popping out. So this is a case which I did 5 to 6 years back. And of late, if you see, there are a lot of articles by Dr. Teriachi, which talks about using corn oil, using EDTA solution while doing instrument retrieval so that it reduces the friction. It reduces the friction in between the file and the canal and makes it more easier for it to pop out. So this is what the research is working on now. But I do not know why I thought that yes, if you put EDT solution inside at that time, because I feel it does work well in cases where you feel that file has got stuck into the canal with a lot of torque. So this is how it came out. So this one case which I would like to show you here, where the instrument has gone beyond the apex in the distal canal. If you remember distal canal, you have enough space in the buccal and lingual direction. And if you see the CBCT which is taken here is previous to what I wanted to. As I mentioned to you before in the presentation, make sure you remove all the GP and then do this, but this was already sent to me. So in this case, removed the caries, did a pre-endo buildup, and did the isolation and coated the canals, the remaining canals with calcium hydroxide so that even if the instrument pops out, it stays in the coronal thirds. So what I did was took mesial angulation, distal angulation. First and foremost thing which I always like doing is bypassing to see if there is any space around it. Create a staging platform using ultrasonic tips. So here I've isolated the instrument. This is the instrument. This is how the canal is in the lingual and the buccal direction. It's big. The next step, what I would do is I would make sure that I have exposed at least 2 to 3 mm or 1 or 2 mm of the tip of the file so that when I apply ultrasonics, it will come popping out. And once it's loose, I would use these extractors or a micro tweezer and hold on to this fragment. And this is how, so sorry, I'll get back to the video again. So, okay, I need to pause it there. So if you see here, this is how the instrument has got logged into my micro extractor. Even this micro extractor, they have changed the design. Now they've got a new one because what happens in this is you're having 2 claws. So and depending on the size of the instrument, sometimes you were not able to hold on with this because it is too thin and the grip of this was not that great. So once I have used, see if you see the size of the instrument is quite big, and I worked in the buccolingual direction with my ultrasonics, made it loose, and then used this extractor to pull it out. There is too much of jumping off this. Okay. So once this instrument was out, now I need to pay attention to why this instrument broke first of all. Yeah. This instrument broke because there was no glide path created, and whoever was using this instrument tried forcing on the instrument apically. So if you remember the technique to be used while working with the rotary instrument, see, this is the one which was created by them, but this was the actual apex, which is quite evident. This was the actual apex, but this was the one created by the dentist, the referring dentist. So if you do not know which stroke has to be used, what settings has to be used, what torque has to be used, you have every chance that you will push it and create your own anatomy. And if you're unlucky, like in this case, you will break an instrument, and then depending on your expertise, you will have to manage it, or you will have to refer it to a dentist who is good at removing instruments. There's this case where if you see or pay attention to, there are two instruments, 1 and 2. Two instruments have been broken here. Now, why do you think the two instruments broke? First one would have been because of cyclic fatigue, over usage, over sterilization. Fine, agreed. That is fine. The second instrument has broken because the referring dentist used a rotary file to bypass a rotary file. So they got clogged. If you see here, it looks like a clog, and it broke. In this case, it broke because of torsional fatigue. The first file at the apical thirds broke because of cyclic fatigue because of the curvature, whereas the one in the middle thirds broke because of torsional fatigue, and it has got torqued inside the canal. So let's see the video here. These are the armamentariums which I have for instrument retrieval. The coronal aspect I have removed with ultrasonics. If you remember the point which I had mentioned to you, if it has got torque or it has got high torque forced inside, what you're supposed to do? You're supposed to apply ultrasonic energy in and around the instrument in the anti-clockwise direction. So the coronal third was out, the apical thirds. Go ahead, hunt for it. Where is it? Then use trephine burr. Here I have used trephine burr, but what you can do is, remember the first slide before we started? We would take a GG number 3 or a GG4, cut it in the middle, and then use it here like how it's mentioned, how I'm showing it to you. Expose the tip of the instrument, and then use the ultrasonics in the inner wall. If you remember, the 6 o'clock and the 12 o'clock Teriyaki kit, which it has two spoon-like ultrasonic tips. So in this case, I used a 6 o'clock one in the inner curvature. The instrument started shaking. See, if you see there, the instrument has started shaking. Now I will use a extractor and try pulling it out. Once it is dancing in the canal, I don't like using a loop system. Personally, I like using an extractor, because with loop, getting it around the file, then pulling it out is more cumbersome for me than just using an extractor and holding on to it and trying to pull it out. So if you see here, I'm struggling even with the extractor because the grip of it is not helping me to hold on to it. But finally, yes, I get a hold of it and I will get it out. 1, 2, 3. Yeah, now it should be out. So that's how I hold it, and it's out. So this is the Zoomax micro extractor. Now what I want you to pay attention to is not the left RVG, but the right RVG. If you see here, so much of dentin I had to remove the coronal fragment, whereas the coronal fragment is supposed to be more easier than the curved fragment. And if it's below the curvature, I was supposed to remove more dentin. But things and techniques have changed. This was broken because of torsional fatigue. So I got it out, but I had to cut so much of dentin. But in the curvature, if I work in the inner curvature here with my 6 o'clock or a 12 o'clock Teriyaki kit tip, I have to just apply energy here. It will come popping out. I would like to repeat few more points here. See, this is a F4 prototype file which is broken from your coronal thirds to your apical thirds, and it's gone beyond the apical thirds. It's gone into the bone, I would like to say here. So what you need to understand is, again, I repeat these points, heat generated and cyclic fatigue created by high frequency waves of ultrasonic tips transferring to the fragment could be the contributing factors to secondary fracture. Secondary fractures of the fragments appear to reduce when the ultrasonic was applied on the inner curvature of wall. Here there is no inner curvature. But what I need to understand is, if I'm using a extractor or anything which holds on to it and tries to pull it out, if you remember the RVG of this case, I would like to go back before I show this. If you see here, from here, there is some space here, but from here till here, around 7 to 8 mm, plus 7 to 8 mm here is locked. It's got torsionally placed inside. It's got a lot of torque in it. So in this case, if I try pulling it out, it will not work. And even if it works, I pull it out with a lot of force and energy. If I can hold on to it, it is going to cause fracture of my apical thirds of the tooth. So see here how I'm struggling. Purposely, I have shot this video to show how you struggle in pulling it out. Whereas when I started using ultrasonics in the inner wall, trying to loosen it in the anti-clockwise direction, it started dancing, it started moving more, it started moving, and it became so loose that I could just pop it out. If you see, I'm using it in anti-clockwise direction, and there it is. It's so loose. I don't even need a micro extractor, just a tweezer will help me see how big the fragment was. And this is how we could remove it. 1/6 distobuccal canal. If you see, it's just below the curvature, but there is not much of an acute curvature. Refine the axis. Make sure where the instrument is, whether this is the instrument or that is the instrument. Make sure you work within the confines. This case did not take me more than 10 minutes, to be honest, including the preparation, including the rubber dam application, axis refinement, creating a staging platform, teasing it out, and just using this Zoomax extractor. Now, why I say this is because this is an initial file. It was not my uh, first shaping file or my last finishing file. So if it's an intermediate file, it's very easy to remove. One of my last few cases which I'm going to show you today, this patient reported to us in 2018, mild tenderness, but patient was not ready to get it done. Came back after a year for a regular checkup. RVG looks fine. If you remember that Rosen article where they said in RVG or periapical radiograph, it's more easy to identify. But the patient was having pain in this condition. So we had to send her for a CBCT. And then we realized that there is a huge lesion which is developing apically to it. Can you see here? It's a huge lesion. So we went ahead, tried bypassing it, could not bypass it completely, could just reach to the apical thirds. Then the next sitting, I could go to the full apical thirds. And to your shock or to my surprise, I got 4 instruments, 1, 2, 3, 4, in which there were 2 rotary instruments, 1 hand stainless steel instrument, and 1 ultrasonic tip also. So had I not paid attention to the points which I mentioned about the cyclic fatigue, the heat created because of cyclic fatigue, the ultrasonic tip, how much of energy has to be applied to a stainless steel, how much it has to be applied to a nickel titanium, and how much to this ultrasonic stainless steel tip, I wouldn't have been successful in removing this. And if you remember the instrument which I removed from the middle thirds, which was in a radix canal with a lot of EDTA solution along with ultrasonic application, I told you that you have to have one tooth isolated in front and one tooth at the back. The reason for that is, see, I'm using a zero size mirror, not a surgery mirror, but a zero endo mirror, and I'm trying to apply my ultrasonic tips. See, I am not able to see the instrument, nor am I able to apply the tip. Both are coming hand in hand. Think if I had just done single tooth isolation and the clamp would be here, the bow would be here, and the jaws would be here, would I have enough space to work around it? This is just to make you understand that if the clamp was here, just here, I wouldn't have been able to even move my mirror or my ultrasonic tips here. So now making it more easy, now see, I've oriented it. It is quite possible. There is enough space to work for both, but you have to isolate one tooth in the front, one tooth at the back. Please remember this. See, this is where I'm able to isolate the instrument. We're able to see it. So what are the instruments which I would recommend is, first and foremost, is a dental operating microscope. For sure, your university has it, your dental school has it. Last time we had given a demo. Last year, same 2 days back. Yes, if I'm not wrong, last year I was there on 26th November. We had given a live demonstration to the all the colleagues there. Next thing which I would suggest is, have any ultrasonic tip which has got long tips, have an extractor. So these are the three things which I would suggest. And once you have acquired all these, you can move to this teriyaki kit. This is the 6 o'clock and a 12 o'clock tip. But most important point is, remember to follow up the cases, because there are a lot of complications. See, everything looks good when I show you I've done this, I've done that, but there are cases where you would lead to perforations, you would break your own instrument, and the case would get more complicated. So you have to be very careful in understanding what complications can happen if you're using ultrasonic technique. So for example, in this case, I have, if I'm not wrong, I've done this 7 to 8 years back. Again, referred for a distal canal, got the instrument out. This looks wonderfully good. If I put it on Facebook, I will. Okay. So sorry. One second. So in this case, we could isolate the instrument. If you see, there is enough space in a buccal lingual direction, and then we could tease it out with ultrasonics. This looks wonderfully good. If I put this case upon any social media, yes, with the images, I did this, and the instrument was out, I would get a lot of likes, follow, and share. But to my conscience, I know what I did. See here. At that time, I was not very good with ultrasonic tips. For me, at that time, removing the instrument was the priority. But now the priorities have changed. Removing the instrument is the second priority. First priority is making sure the remaining dentin around it is maximum. That means I remove as least dentin around the instrument and get it out. So just don't go by the images which are put up on social media. Half the times they are dangerous. So I would say, don't forget this slide. I might have a microscope, I might have ultrasonic tips, but if I have not mastered the technique, I would not know how to use it. So same thing here. This guy is having so many ladders. He's using the heap of ladder to peep on the other side of the wall, whereas he can just use one ladder, climb it, and go to the other side. So what is the inference of this slide is? Again, I might have a microscope, I might have so many broken cases, I might have all the ultrasonic tips which I want, the university will provide me. I can tell Dr. Diane, I want this, I want that, and I'm sure she will make sure things are arranged for you. But if you do not know how to use it, you don't practice enough to use it, they will not be enough. And always remember, whatever you learn, teach to your colleagues, because while teaching, you're learning again. So I would like to thank you all for your patient listening. I would like to thank all my teachers, mentors, and friends. And I would like to especially thank Dr. Deanne for having me here for this lecture, and so kind of her. Any doubts or queries you have, these are my details. You can ask me anytime on this. So I think we are done with the session, Dr. Diane.
Okay, thank you, Professor Anuj. We are now waiting for the questions from the audience. Mohon untuk peserta bisa menuliskan pertanyaan di fitur chat Zoom ya. While we are waiting for
the questions,
those are interesting cases with the broken instruments. It's quite sometimes challenging in our daily practice.
Yes, I agree. And if people are not asking questions, that means they have understood everything or they have not understood anything.
Yes.
Okay, there's one question: how to prevent the instrument fracture?
Yes.
Okay, let's put it into points 1, 2, 3. Number 1, if you have created good glide path, first thing. Second thing, whenever you take the instrument into the canal, don't leave it there for more than 4 seconds. Get it out, wipe the instrument and check for the flutes. Third point, don't overuse the instrument. See, wherever I lecture or with whomever we speak to, I always ask them, how many times do you use the file in the canal? They say, till it breaks. So that is one thing which you need to pay attention to. One point which I have missed out here is, first and foremost, when you've put your 10 number file into the canal, and when you take it out, take the file, face it towards your eyes and rotate it into 360 degrees. Once you see the file in when it is pointing towards you and you rotate it 360 degrees, you will see the multiple curvatures and you would know where it is an acute curvature, where there is a gradual curvature. If it's a gradual curvature, there's nothing to worry. But if it's an acute curvature, you have to be very careful that you create a glide path with at least 15 or 20 number hand size file. Next question is, what is the consideration to remove or not to remove the fractured instrument?
Yes.
Okay. If there is no periapical lesion, I would think of, first and foremost, I would think of bypassing it for sure. Always and always. See, root canal system is like a cylindrical tube. One is apex, one is coronal third. We have enough articles which talk about coronal third sealing and apical third sealing. If I can seal both the ends, that is the aim of doing a root canal. If I can seal both, that is a coronal end and apical end, I would get success. So sometimes what happens is we are not able to bypass, we are not able to even remove the instrument. So keep giving calcium hydroxide dressings for every week for at least 3 weeks. See if the patient is asymptomatic and the lesion is not growing. And every 6 months, keep it on a follow-up radiographs to know whether there is any increase in lesion size. So that is the only way you can think of putting these things for this question. Any other question? I hope I have answered you, Dr. Ikarishta. Any other questions? Oh.
Mungkin ada pertanyaan lagi dari adik-adik. Bisa langsung atau melalui chat.
I think all the students are sleeping at their home.
Some of the participant is the new student.
Okay.
For this year, so maybe
they've not understood things.
Yeah, and a little bit not confident maybe.
So once this corona is over, and when I come down there, you can ask me personally also.
Okay.
Ya. Silakan Dr. Eri.
Okay. And one more. I'd like to ask you, Professor Anuj.
Yes, Eric.
What do you? How can you handle those root canals that has been treated with broken instruments? Like the root canal is become larger, right? And doesn't it weaken the tooth structure?
See, if you remember the second last slide which I showed you, if you remember, I'll just show you again.
Yes.
This one. You remember this slide? I've done this myself 7 to 8 years back. So as I mentioned here, yes, you have to be very careful, not only for removal of instrument. Don't just run behind removing the instrument. Run behind removing the instrument with minimal tooth structure loss. Plus, nowadays we have bioceramic sealers, we have putty MDA. So things have become easier, but again, I would like to stress, make sure the remaining dentin thickness has to be as maximum as possible. So Eric, coming to your point, yes, we are weakening the tooth, but with the materials which are available to us, like MTA, if I can pump the whole canal, or I can fill the whole canal with MTA, things become much more better. And if you've seen Yoshi Terachi's cases, he is using only MTA for obturation after instrument retrieval. It works well. It works well for me. I have enough cases which have worked well for me.
And the prognosis is also.
Yes, if I'm saying more than 7 to 8 years, that's why I put that chart saying that I started in 2011 and the journey continues, and I'm making sure that all of them come back for follow-ups. So that was I had taken it on my consent that you have to come down for follow-ups for things. Yeah, so it's worked well.
I think there is one question, Dr. Eri, in chat room.
Yeah, which ultrasonic tip that suggested to manage the broken file? Again, it's from the Teriachi kit, which is TRFK or TRFK 6 o'clock or TRFK 12 o'clock. Okay.
One more, Dr.
Yeah.
Anuj, in chat
Yeah.
room.
Yeah, by Dr. Grace. It's a wonderful question. When we are removing the broken instrument with ultrasonics, sometimes the broken instrument getting deeper into the root canal. Could you give explanation and some tips to prevent it? If you remember one of my slides where I told you to take a screenshot, in that, what it mentioned was apply the ultrasonic energy in and around the tooth, around the broken instrument, not on the tip of the instrument. If the instrument is so loose in the canal, again, I would say use the ultrasonics in and around it, use a loop system or an extractor system, hold it and get it out. If it is a maxillary, you're lucky that if you irrigate it with a lot of pressure, it's going to fall down. But if it's a mandibular, it will come up and pop down again. So that is what you need to pay attention to. I hope I have answered your question, Dr. Grace.
Thank you, Professor.
Yeah. Dr. Netanya has asked me what complications can occur after removing the instrument. If I have been, okay, I shouldn't be using such language, but yes, if I've been an idiot like this, there's every chance that there's going to be a root fracture here. Sooner or later, patient is going to have lesion developing up. But of late, if we are using to pack the whole canal with MTA, even if it fractures, there's going to be nothing happening because MTA is so biocompatible that and plus it's osteointegrative and osteoinductive. So things become better. I hope I have answered your question, Dr. Nathaniel.
Thank you Prof for the answer.
Yeah. Dr. Diane, you need to ask me a question.
No. Oh, one more. What do you think about the chelating agent to decrease the what is that the surface tension? Is
Yes, it works very well. I would say, but the thing is, you have to make sure that when you're applying your ultrasonic tips along with chelating agent, you have a path created. That means when the canal is dry with the instrument, take your tip, practice where you need to apply it. Then take it out, put your ETA solution, apply it at the same place, because now you're not able to see where you're applying it. So this would need a little more practice. But yes, it works wonders, especially with the files which are talked inside. It helps. It does help.
Okay. Yeah.
So now I have a question for Dr. Diane. So when are you making our world free of COVID?
Yeah.
That is the biggest question for all of us. Just hope things become normal and we all get safe, and all these students, parents, and family members stay safe. That is the thing which is the most troubling thing, especially small kids and elderly parents.
Yeah. You too.
Yeah. So anything else which I need to answer, or I'm okay with it? It's done.
I think it's enough. Maybe we can get picture together.
Yeah, for sure, we can do that.
Minta tolong videonya supaya diinikan semua ya. Oke. Bentar saya.
So all of them have to come online.
Yes.
Half of them were sleeping so that they cannot be seen.
Okay, 1, 2. Cheers. Wait, I second page. Okay. And then the last page. Okay, thank you so much, Dr. Anuj. And once more again, thank you for all audience. Maybe we can meet again in the future meeting. Thank you. See you.
See you. Bye-bye.
Bye.
Bye. Good day.
Thank you.
Thank you, Prof.
My pleasure.
Thank you, Prof.
I'll be leaving the meeting now. Thank you.
Yeah.
Good day. Bye-bye.
Thank you.
Bye.
Mohon maaf, dokter.
Ya. Kenapa, Dek? Oke, thank you ya. Kita soalnya ada acara lagi. Makasih.
Kasih, Dok.
Kasih, Dok.
Makasih, dokter.